we're at KCM Clinic in Poland. My name is Colette and I'm a patient manager at Qunomedical, and this is Dr. Budzynski and we're going to be talking today about bariatric surgery.
My name is Andrzej Budzynski. I'm a surgeon. I work as the surgeon for almost 30 years. I'm an abdominal surgeon. Among others, I'm a bariatric surgeon.
How many surgeries have you done over the years?
I don't count, actually. It's the quality of you provide that matters. The digits are there are certainly at least 4 digits, not 5, but 4 certainly, but I can't tell you precisely.
And in regards to which surgery you suggest more, would you recommend the sleeve over the bypass, or is it patient by patient?
It depends. There are many issues here. We don't have a standard, and actually there is nothing that is comparable to standard because it's very dependent on the surgeon who does it and the surgeon's preferences. The good bariatric surgeon is the surgeon who has in his armamentarium a lot of procedures and can try to adjust it to the patient's needs. Generally, sleeve, which is probably the most popular procedure right now, it's a very good procedure to start with. There are some conflicting data about metabolic problems, for instance diabetes. And there are data that suggest that bypass is far better than sleeve. There are data that there are no differences, but still generally, if I have an older patient with diabetes, especially diabetes on insulin, I would think about bypass. I would be rather reluctant to do a bypass in very young patient. Bypass is excellent. It has almost 50 years of history, so we know how the patients look like after bypass, after 20 years, 30 years of bypass. And there is another very important information, and I say it to every patient, especially for complicated cases. So revisional surgery, I had a band, the band was removed, now I want a bypass, and I tell the patient, I will see what I'll be able to do. So there are some technical issues. Sometimes it's impossible to fulfill the patient's request. Our body is sending us signals, but the strength of those signals differs. So strict signal, I'm hungry, is probably one of the strongest signals that we may have. Evolution invented it because the real hunger, not enough food, was something that may kill a person. So people were doing terrible things because they were hungry. We have also the signals that you ate too much. But this is like whispering. It's very easy to disobey those signals and say, come on. And it's like a story of the boy that was yelling, wolves, wolves. After a couple of times, nobody was listening to him. Obese people learned how to use their GI tract in the wrong way. Not because they are hungry, not because it's the way how we are delivering calories. It is only because it's nice, it's pleasure, it's fun, it's the part of our social life that we eat. And we are trying to please ourselves. Surgery is giving a patient new GI tract with a new chance to learn how to use this GI tract properly.
For those patients, when we saw you doing the gastric sleeve earlier, I heard you mention that for those kinds of revision surgeries, there should be a waiting period. Could you give our patients a little more information into why we should wait a few months?
Actually, those are 2 different issues. First issue is balloon. It's just a temporary method. I see a place of balloon in the patients who are tremendously obese. So super obese patients, BMI above 60. If you want them to lose at least 20-30 kilograms so that we will be able to perform a good sleeve resection, that's an excellent indication for a balloon. Another good indication is patient who is not absolutely convinced. The patient who wants to lose weight, but he does not know how he will tolerate the food restriction related to sleeve. So he wants to have something that is reversible. Sleeve is irreversible. That's the decision for the rest of the life. So insertion of the balloon in the patient who hesitates is an excellent idea. Balloon stays there for a half year. Now we have balloons that can stay there for a year, but it's still time span that is very well defined. Band is a different problem because there are many reasons why we are removing band. It may be not effective. It may be complicated, it may be ruptured, migrating, stenotic, slipped, infected. Many reasons why we do so. You have to remember that a piece of plastic, no matter how technologically sophisticated, that stays there in your body and irritates your body chronically for many years. So when the patient comes to me requesting for one-stage procedure, I always tell the patient, okay, as long as it's safe. If it's safe, I will remove the band and try to do sleeve or bypass, whatever we decide is better for the patient. Priority of the bariatric surgery, that it has to be safe. We are here to help the patient, to prolong the patient's life.
Thank you very much for
You're
meeting
welcome.
with me today and
You're
answering
welcome.
some of our patient questions.
You're welcome.